Thank you. I'm going to turn it right over to Commissioner David Cutler to introduce our keynote speaker for today's hearing.
David, thank you. And it's an honor for me to introduce our keynote speaker, David Williams. David is my colleague at the Chan School of Public Health at Harvard. Florence Sprague Norman and Laura Smart Norman, Professor of Public Health, also in the Department of African and African American Studies in the Department of Sociology at Harvard. I think when the history of this era is written in terms of its impact on health, to be sure there will be some credit accorded those who developed vaccines and new treatments and so on. There will also be a chapter, if not multiple chapters, on people who have helped to address the social determinants of health. And David is probably the #1 person in the world who has done that. He brought to life and to study our knowledge of racial disparities in health, developed an everyday discrimination scale that people use to measure the impact of regular interactions, regular discriminatory interactions across the spectrum. He's shown the relationship with health. He has also gone through enormous amounts of literature to demonstrate the many different ways that racial issues and other stereotypes affect health in the population. David is the author of 475 papers. He's been on numerous editorial boards. He's a member of the National Academy of Medicine, formerly the Institute of Medicine, the American Academy of Arts and Sciences. And it's just a great pleasure to be able to listen to him. He's one of the most enlightening speakers and writers that I have ever heard. So I'm not going to delay it any farther, and I'm going to turn the virtual microphone over to David. Thank you so much for joining us.
Thank you so much, David, for your very kind words of introduction. It's truly been an honor and privilege to accept this invitation from the HPC. Is someone going to move my slides for me, or do I control them myself? I'm a little unclear.
We'll move them for you. Please just say next slide. Thank you.
Okay. It's much easier if I do it myself, if that's possible, but if it's not, it's okay.
Sorry, if we could do it for you, we'd appreciate it. Thank you.
Yeah, there's a certain rhythm you get in your presentation that goes much smoothly, but it's okay. We will proceed. So what I will do is to try to give you a high-level overview of the challenges we face, but really also give emphasis to the opportunities that we have in terms of dealing with them. The next slide talks about COVID-19 disparities in the United States, and this is the big picture, and you've seen them. You can see the excess risk for African Americans and Latinos, and the next slide shows you the data broken down in a way that you can't possibly miss the point. If all racial ethnic groups had died at the same rate as white Americans, 21,800 Black Americans would still be alive, 11,400 Latino Americans who died would still be alive, and there'd be 750 Indigenous Americans still alive. The next slide indicates that the patterns that we see with COVID-19 in the US is a global pattern, and it's a global pattern for a broad range of outcomes. The next slide illustrates that by looking at infant mortality in the United States for 2015, and you can see the excess risk for African Americans and Native Americans. The next slide shows you data for the UK and shows you that in another society where everyone has access to care, you still see striking racial disparities in health, with African American, Black from Africa, Blacks from the Caribbean, Pakistanis have elevated rates of death. How do we make sense of this? The next slide talks about how do we make sense of this? Socioeconomic status is income, education, occupational status is a powerful and potent driver of variations in health around the world. And as the next slide indicates, that if we think of socioeconomic inequities in the United States, we see fairly striking patterns. One example, national data for the United States, looking at the panel study of income dynamics, and you can see low-income Americans have an overall death rate 3 times that of Americans with incomes over $115,000. And there's not a threshold effect, but every higher level of income is associated with a lower risk of overall health. Next, we can see that the patterns of racial ethnic inequities in health, the next slide, there are large racial inequities in socioeconomic status in the US. The next slide shows you income data for the US for 2018. And the next slide shows you the same data broken down by a way that you can't possibly miss the point. So in 2018, for every dollar of household income white households receive, Asian households receive $1.23. Asian households are heavily made up of immigrants, and they have more persons contributing to household income than any other group. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Latinos receive 73 cents, and Native Americans and African Americans receive 59 cents. What is stunning about that 59 cents figure in 2018 is that is identical, go back, to the black-white gap in income in 1978. You heard me correct, I did not misspeak. In 1978, the peak year of the narrowing of the black-white gap as a result of the anti-poverty policies of the 60s and 70s and the civil rights policies of the 60s and 70s, the gap had been narrowed to 59 cents. And in 2018, the gap is 59 cents. Has it been stable over time? No, it fell throughout the decade of the 80s. It was not until 1994 it got back up to 59 cents, and it's been a penny up and down since then. Importantly, my point is the persistence of the racial inequities in income are much larger than clearly most of my students think. The next slide makes the point that the large racial gaps in income markedly understate the racial gap in economic status. Next slide makes the point that what do I mean by that? You see, income captures the flow of resources into the household, but wealth, assets, gives us a sense of the economic reserves that households have for income. And the next slide shows the latest data from the Federal Reserve Board showing income differences in wealth. Keep the slide moving. For every dollar of wealth that white households have, black households have 10 pennies, and Latino households have 12 pennies. So these are striking persistence of differences in access to economic resources. Next slide. Just to put this into context, I'm showing you data for the UK, where we see a similar pattern of racial differences in wealth. For every pound of wealth that the white British have, you can see Indians have 95 pence, Pakistanis 50 pence, blacks from the Caribbean 20 pence, blacks from Africa and Bangladeshis 10 pence. So we are seeing kind of inequities across racial groups, across two societies that are quite large and striking. Next slide. When my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in income and education, occupational status. And if we looked at persons of the same racial ethnic background at different levels of income and education, race wouldn't matter. We now know that life is more complicated, and I'm going to illustrate that with national data for the United States, life expectancy at age 25. And the next slide shows that at age 25, the average white person, one more click, will live 5 years longer than the average African American. One more click. If we go to one more click, it shows that there's a 6.4-year gap between whites with a college degree or more education and whites who have not finished high school. Importantly, the gap within whites by education, it's also true by income, I'll only show you education data in the interest of time, is bigger than the black-white gap. And the next click will show that the gap within African Americans by education is 5.3 years between African Americans with a college degree or more education and an African American who has not finished high school. At the same time, economic status matters profoundly for health, regardless of your race. At the same time, race matters profoundly at every level of economic status. As the next click shows, that if we look at black and whites who have not finished high school, keep going, we can see a 3.1-year gap between white high school dropouts and black high school dropouts, and that gap widens, the next click shows, as education increases. And this is arguably one of the most stunning statistics I'm showing you today. that the best of African Americans, and remember this is national data for the United States, those with a college degree or more education have lower life expectancy, next click, than African Americans, than whites who have a college degree, than whites with some college, than whites who have completed high school. So what do these data tell us? They tell us profoundly there's something about race that matters for your health, regardless about income and education, but there's also something else profound about income and education that matters for your health. I want to bring this home with the next slide, showing you data for the UK with COVID-19. And this slide will unfold. And so just keep clicking when I ask to click once. So here we have, for men in the United Kingdom, COVID-19 deaths. For Black men in England and Wales, the overall death rate, age adjusted, is 4.2 times that of whites, although everyone has access to the National Health Service. For Bangladeshi, Pakistani, it's 3.6 times. For Indians, it's 2.4 times. Now, what happens when we statistically adjust, as the next clip would show, for income and education and housing tenure and so on, the gap is reduced, but there's still a 90% excess death rate for Blacks in the UK, even after we've taken all of these socioeconomic status factors into account. And if we go, the next click would show the data for women, and you can see, similar to the pattern for men, a very large gaps by race, ethnicity in the United Kingdom. And then even after we've taken income and education and other demographic factors into account, as the next click shows, you still see the persistence of these differences. So across two societies, we are seeing something profound taking place. Even after we've looked at income and education, something else appears to be driving the disparities that we see. And the next slide raises the question that researchers have been asking for the last 25 years. Could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? And the next slide indicates, as we think of racism, what do I mean by racism? When I use the term racism, I'm primarily referring to a social system, one that categorizes and ranks, devalues and disempowers, differentially allocates opportunities and resources to individuals or groups. It's premised on an ideology of inferiority. And yes, it can lead to negative beliefs and attitudes, prejudice and stereotypes. Yes, it can lead to differential treatment by individuals and social institutions, but the heart of racism is in fact this societal system. Next slide. As we think of racism, I want to make the distinction that is very widely made in common speech today of between individual discrimination and institutional, structural, or systemic discrimination. That's discrimination that's really embedded in the normal processes of social institutions. The next slide, I want to give you an example of this racism and how it works. This is national data for the United States. This is the 2012 presidential election. How long did Americans stand in line on average to vote, at a precinct to vote? African Americans on average to 23 minutes, whites to 12 minutes. You can see 19 minutes for Latinos, variation across groups. Importantly, although we see striking differences, none of this reflected individual behavior of local precinct workers. Instead, as the next slide indicates, it was heavily driven by where you voted and what were the budgeting and space constraints, what was the local administrative procedures, what was the level of staffing. So it was all about policies and administrative procedures, but that led nonetheless to dramatic variations in voting. Let me take that to another level by talking about one of the most powerful institutional mechanisms of racism that operates in American society today, and how that shapes access to opportunity and health in many profound ways. The next slide talks about segregation as a fundamental driver or example of institutional racism. And the next slide makes the point that segregation, it's a historic legacy, but its negative effects still persist in American society today. As the next slide indicates, John Sell wrote a book about the history of segregation. He shows that the framers of apartheid in the early 20th century looked across the Atlantic, saw residential segregation, and thought it was brilliant. And so in South Africa, built apartheid on the segregation they had seen developed in the late 19th century in the United States. Importantly, Sell argues that segregation was one of the single most successful domestic policies of the 20th century in the United States. Why would he say that? Well, the next slide gives you my little illustration of how segregation operates. It is like a toxic emission produced by an industrial plant. And once segregation enters a community, valuable resources disappear. They disappear, as the next several clicks will show, valuable resources like quality schools. Let's keep going, as safe playgrounds, as good jobs, as healthy air and water, as safe housing. Let's keep going, as transportation, as access to high quality medical care are examples of resources that disappear as segregation enters a particular context. How powerful is segregation? The next slide illustrates a study conducted by two Harvard sociologists back in 1995. They studied 171 largest cities in the United States. And they said there's not even one city, because of segregation, where whites live under equal conditions to those of blacks. And the worst urban context in which whites reside is considerably better than the average context of black communities. Well, that's 1995 study. What do we know today? The next slide introduces us to the Neighborhood Opportunity Index, one developed by Dolores Acevedo Garcia from Brandeis University. It captures across 24 different indicators of opportunity at the neighborhood level for every county in the United States. And what the next slide shows is that when you look at the Neighborhood Opportunity Index in the 100 largest metropolitan area of the US, 2/3 of all black children and 58% of all Latino kids, 53% of all Native American kids are living today in low or very low opportunity neighborhoods. That's compared to 1 in 5 white and Asian kids. At the opposite end, who lives in very high and high opportunity neighborhoods? Almost 2/3 of white and Asian kids. So it's the opportunity at the neighborhood level, striking disparities still persist in the United States today. These disparities, the next slide introduces us to the idea that they have created racial ethnic differences in socioeconomic status. This is something the next slide illustrates that David Cutler documented for us back in 1997, showing that statistically, if you could eliminate residential segregation, you would in fact completely erase black-white differences in income, education, and unemployment, and reduce racial differences in single motherhoods by 2/3. More recently, the next slide illustrates the work of another Harvard economist, Raj Chetty, who has done an intergenerational analysis using all census tracts in the United States between 1989 and 2015. He looks at the outcomes for the next generation of white and black children, comparing those who begin at the same place in life, controlling on parental income. And he finds that black boys in America, in 99% of census tracts, controlling for parental income, do worse than their white counterparts, even when they start out at the same level of income. Why? They live in neighborhoods that differ in access to opportunity. Black boys do well, as white boys do, if they are in neighborhoods with good resources, but essentially there are no such neighborhoods or very few such neighborhoods in the United States. The next slide. The point that I am making is this systemic measure of racism, residential segregation, has produced in the United States large racial inequities in multiple domains of life that do not, in fact, reflect a broken system. Instead, it reflects a carefully crafted system functioning as planned, successfully implementing social policies, many of which are rooted in racism. This is not an accident. This is not an act of God. Racism has truly produced a rigged system in the United States. Next slide. what low economic status means when persons lack access to opportunity, live in segregated neighborhoods, lack wealth. It means, as the next click shows, even though we are in the same pandemic, we're in the same storm, we're in different boats. And some boats are much better able to weather the storm than others. Next slide. What these conditions also mean is, as was so powerfully illustrated in the video we saw of how access to resources varied dramatically by the resources that households and communities have, that in the face of COVID-19, low-income communities, low-income households face unique challenges that mitigates their ability to fight the pandemic. Next slide. There is a large body of evidence that being lower in economic status, being populations of color, living in disadvantaged segregated neighborhoods leads to higher levels of exposure to economic stressors like difficulty making ends meet at the end of the month, higher levels of unemployment, higher levels of psychosocial stresses, the loss of a loved one, higher levels of racial discrimination, and higher levels of physical chemical stresses. And all of these stresses combine in powerful ways to put these populations at risk. Let me illustrate that, as the next slide shows, with data from some colleagues of mine at the Harvard Chan School of Public Health that showed the relationship between air pollution and COVID-19, and that poor and minority communities are at higher risk of being in neighborhoods with high air pollution. And if you live in those conditions, then you are more likely to get a severe case of COVID-19 and more likely to die of it. Another stress that the next slide introduces is the stress of discrimination that Martin Luther King suggested could have negative consequences for health. The next slide illustrates one measure of discrimination, experiences of discrimination as a type of toxic stress. The next slide illustrates the everyday discrimination scale that, as David Cutler mentioned in the introduction, captures just little indignities. Being treated with less courtesy and less respect, receiving poorer service than others, people acting as if they think you are not smart or they are afraid of you. Little indignities on a day-to-day basis. What the next slide does is illustrates from more than 200 papers published from around the world of the negative effects of everyday discrimination. High levels of everyday discrimination are linked to incident metabolic syndrome and incident cardiovascular disease and incident breast cancer. High levels of everyday discrimination is linked to a number of subclinical indicators of heart disease and to increased rates of blood pressure, poorer sleep duration, higher levels of inflammation and other biomarkers, higher obesity, and higher mental disorders. So a broad range of risk factors and preclinical indicators of disease have been documented globally linked to just the stress of discrimination. Next slide. And what this all means, researchers are using different terms to describe it. But the cumulative negative impact of exposure to psychosocial, economic, physical, chemical, toxic, the stress of discrimination is really leading to wear and tear on the organism, so that for the average person, your age, chronological age, captures how long you have lived. But for persons of color in the United States, your age is not only telling you how long you have lived. Because you are living under worse environmental conditions, your age is also capturing how long you have been exposed to bad environmental conditions, and therefore how physiologically compromised you are as a result of such exposures. Weathering is one of the concepts used to describe this phenomenon by Arlene Geronimus, but these are other terms that are being used. And what we see profoundly, and we see it whether you look at measures of telomere length that shows accelerated aging among populations of color. You looked at measures of biomarkers at particular ages, and you see a 7.5 to 10-year difference in biological functioning at the same chronological age. What this all means, as data from the CDC shows in the next slide, is that African Americans and other populations of color at the same age have markedly earlier onset of disease. We see this for high blood pressure. The next slide shows exactly the same thing for diabetes. And certainly, this matters profoundly for making sense of COVID-19. The next slide gives us an example of a study done in New York City. 12 hospitals, almost 6,000 patients. 57% of all those patients hospitalized had hypertension, 42% had obesity, 34% had diabetes, 18% had heart disease. And as the next slide shows, if we look at among those patients, only 6% had no condition, and only 6% had one. So 88% of all the patients hospitalized had two or more. And what I'm showing you is that the living and working conditions of disadvantaged populations are putting them at risk for a broad range of conditions that makes them particularly susceptible to COVID-19. Next slide. What can we do? What are the potential solutions? Next slide. I want to raise the point that there are several things we need to do. And I begin with one that I think on the short term is really critical. It's short-term economic relief. If the feds don't act, the state needs to act. We need to minimize the burden of economic stress on the health of the most vulnerable. The next slide illustrates two publications just from this week that illustrates the depth of the recession and economic collapse for populations of color. One study showed that only 25% of workers laid off or furloughed at the height of the pandemic have so far received unemployment benefits. Many have applied, and they are at different stages, and there are multiple barriers in receiving benefits. And the next study shows that there's dramatic unequal impact of the recession. Whites have recovered more than half of the jobs lost between April and February. In contrast, continue to unfold in that slide. Blacks have recovered a third. Hispanics have seen the largest job losses and have the most ground to make up. One important take-home message as well, given the data I showed not just on income, but on wealth, if we are going to be effectively meeting the needs of disadvantaged communities, we need to consider including assets and wealth as part of the assessment of need, else we dramatically understate the difficulties and challenges disadvantaged communities face. What else do we need to do? The next slide. I have argued that simply providing equal access to care will not solve the inequities problem, and I brought that home with data from the UK to illustrate that. At the same time, I think we need to be much more strategic than we are in the innovative use of medical care to address racial ethnic inequities in health. And the next slide is going to give you an illustration of what is possible by looking at an innovative program done by the state of Delaware. It was a statewide program that provided free colorectal cancer screening to everyone in the state, essentially, and then added colorectal cancer treatment to the program, included special outreach efforts as well to African Americans and other populations. What has been the results of this program? Fairly dramatic success. The next slide illustrates what has happened with colorectal cancer screening. You can see from 2001, when the program was implemented, to 2009, they have eliminated the racial gap in colorectal cancer screening. And the next slide shows that they have also virtually eliminated the racial gap in the incidence of colorectal cancer by markedly reducing the rates for both blacks and whites. And the next slide shows that they have virtually eliminated the racial gap in colorectal cancer mortality. So fairly striking, fairly targeted strategy. This is not going to be true for every medical procedure and every potential medical intervention, but we need to be much more aggressive in identifying those interventions when we can produce results like this. And as the next slide shows, this comprehensive program in the state of Delaware, yes, had a cost of $7 million annually, but had savings of $8.5 million annually because of the reduced incidence of colorectal cancer. So it literally paid for itself. So we just need to be much more creative with solutions like that. The next slide, we want to talk about other solutions. We need renewed investments in eliminating inequities in the receipt of high quality care. Back in 2000 to 2003, I served on an equal treatment report, the next slide, that illustrated this gap that persists in the United States. And there's research suggests it's still a problem, and we need to not lose sight of that fact. Next slide. We also need to build more health into delivery of medical care by putting greater emphasis on the need to diversify the workforce to meet the needs of all patients. The next slide illustrates a study that was just published by PNAS last month. What it showed, studying 1.8 million hospital births in the state of Florida over multiple years, when cared for by white doctors, Black babies are 3 times more likely than white newborns to die in the hospital. That disparity was cut in half when the Black babies were cared for by a Black doctor. There's a lot we still don't understand. We don't know what conditions this pattern exists for. We don't fully know in detail all the drivers of it, but it illustrates the potential importance of having a diverse workforce, and we are not doing well right now, as the next slide illustrates. This report from the American Association of Medical Colleges that talked about the fact that in 2014, there were fewer African-American males in the first year of medical school than in 1978. Another strategy, I would argue we need to address election-related stressors to minimize pathogenic consequences of sociopolitical stress for our populations, even as we are in this election season. And I'm drawing on here the next slide, a paper published in PNAS last week that I and my colleagues published. We used data from Kaiser Permanente, Southern California, and showed that in the 2 days after the Trump election in 2016, there was an increase in hospitalization for heart attacks and strokes within that system that had more than 4 million lives. Now it had persons who were had insurance, but the study emphasizes that stress linked to political campaigns, rhetoric, election outcomes literally can directly harm health, and both patients need to be aware of this, and healthcare providers also need to be aware of it. Next slide. I think our long-term strategy, given the centrality of segregation, given the centrality of inequality at the neighborhood level, our long-term strategy has to be making the investments to minimize, neutralize, and dismantle the systems of racism that create inequities in health. Next slide. There are a number of those systems mentioned here. We need to ensure access to care. We need to invest in early childhood. We need to reduce childhood poverty, enhancing income and employment opportunities for youth and young adults, improving neighborhood and housing conditions, providing care that addresses the social context, all examples of strategies we need to implement. I want to elaborate on a couple strategies in more detail. The next slide is going to give an example of what can be done in terms of improving neighborhood and housing conditions. Next slide. This is the example of purpose-built communities. The first project was in Eastlake, Atlanta, and it has had dramatic results in terms of what is possible if we put our minds to it. So next slide, I'm going to go through a series of slides that's going to show what Eastlake, Atlanta looked like. Let's keep going. Back in 1995, keep going. The first slide shows the level of safety as a problem, a very high crime rate. The next, keep going, slide shows it was public housing. The next slide shows that only 13% of adults were gainfully employed, and the next slide shows that it was one of the worst performing schools in the state of Georgia. Next slide, it illustrates what the dramatic transformation has been. There's been a 19% reduction, keep going, in violent crime in that public housing project. Half of the units are qualified for public housing, half are at market rate, all able-bodied persons are employed, and although over 60% of the students qualify for reduced price school lunch, the school is one of the best performing elementary schools in the state of Georgia. Next slide. It illustrates what can be done. And here are some key principles of the purpose-built model of comprehensive, integrated, place-based solutions, providing high-quality resources to address all of the social problems that disadvantaged communities face simultaneously. Shirley Franklin, former mayor of Atlanta, is the chair of the board of the purpose-built communities. and purpose-built is promising free technical assistance to any community in the United States who wants to replicate their model. It shows that the public housing department, with a local community group, with investors, can come together and dramatically transform the disadvantage that often exists in many of our challenging communities in the United States. Next slide. So finally, and maybe arguably most difficult, what is the big thing we need to do? My long-term strategy 3 is we need to raise awareness levels of racial inequities and build political will to address them. The next slide illustrates what's holding us back. What are the barriers to address? Next slide. The elephant in the room, next slide, is these 3 challenges. We need to raise awareness levels of the problem of inequities in health. COVID-19 has raised awareness level, but prior to COVID-19, most American adults were unaware that racial ethnic inequities even existed in life expectancy or infant mortality. And second, we need to build the science base that will guide us in developing the political will to address these inequities. And third, we need to build empathy. That is, we need to identify how do we tell the story of the challenge of the disadvantage that we've saw so powerfully on video and I've been talking about in ways that will emotionally connect and resonate with the general public of the United States. And this point, next slide, is something that W.E.B. Du Bois said so eloquently. A great African-American social scientist of the late 19th century published a book in 1899 entitled The Philadelphia Negro. And he has a chapter in that book on Negro health. And he lays out the inequities that existed back in Philadelphia in 1899. And as he comes near to the end of the chapter, Du Bois penned these words: the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And he says, there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. So he saw the fundamental challenge is that we don't really care. He called it the peculiar indifference. Scholars today call it the empathy gap. And the next slide gives us a recent review paper on the empathy gap. It's a global phenomenon. And that is not looking at what people say they feel, but looking at how the brains of adults respond as they view the suffering of persons of someone of their own race compared to someone of another race. There is a racial in-group bias where we have stronger empathic neural responses. We sympathize and empathize and feel the suffering of what happens to someone of our own race compared to someone of a different race. And we need to figure out how we can much more effectively build empathy, because that empathy is necessary to build the political will to get the initiatives that need to be done to address these inequities in health. Next slide. Why should we care? I want to end on the point that there's lots of reasons for us to care, and we should care because of the values we share as a people and the values and principles we live by. But I also want to make the point that there's a mountain scientific evidence that we should also care because allowing these inequities to continue is costly to all of us. Next slide. This is the cost of inactions that these inequities, racial and socioeconomic, costly to our society. Next slide. This is work of Bob Cheney, Will Dow, and other economists showing that if all Americans had a health of the college graduates, the best off in the U.S. in terms of health, the U.S. economy would save $1 trillion annually. That would, if we could eliminate socioeconomic gaps in health. The next slide shows what Tom Levis and Darrell Gaskin documented for racial disparities in health, costing the U.S. economy $309 billion a year. The next slide gives examples of a work done by the Kellogg Foundation and Altarum Institute. And they have calculated what would be the annual additional economic benefits if we eliminated racial inequities by 2050. And the annual additional benefits are $8 trillion to US GDP an additional 3.3 trillion in earnings. The next slide gives more examples. Additional 2.6 trillion in consumer spending annually, additional 1.4 trillion in federal tax revenues. And so you can see an amazing number of benefits. Next slide. Citigroup recently calculated that racism has cost the US economy $16 trillion loss in GDP. So my point is, these inequities, in addition to the moral reasons and the values reasons we have, they are actually a drain on us economically, a drain that we cannot sustain as we look to the future. Next slide. I want to leave you with two quotations, two of my favorite speakers who have inspired my life. Martin Luther King said, "True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring." We have inequities that are not happenstance. They have been produced by edifices, then we need to work together to restructure them. And finally, I leave you with the words of Robert Kennedy. Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. We, each one of us, can be a tiny ripple of hope, and together we can work together to sweep down the mighty walls of oppression and resistance. Thank you so much for your time and attention today.
David, that was phenomenal. Thank you.